great pleasure to welcome today student Dr. Ginger Chant. Student Dr. Chant is an anatomy fellow on the Kansas City campus. She attended Baylor University for her undergrad degree. You're up there. And KCU for her master's in biomedical science degree. Currently in between second and third year of med school, Ginger is assisting with anatomy education in the Gross Lab, in addition to working on a research project. Her interests are in anatomy, pathology, histology, and teaching, and she plans to pursue pathology as a specialty and work as an adjunct professor in the future. Awesome. Without any further ado, student Dr. Chant, take it away.
Thank you, Dr. Staudinger, for that great introduction. I'm really excited to talk to you today about my study, which is the association between age and renal artery stenosis classification, a cadaveric study. These individuals listed on this slide are my wonderful research team, Christoph Gutowski, Janice Wang, Dr. John Dobson, Dr. Larry Seegers, and Dr. Jennifer Dennis. So we are going to do a brief introduction on clinical relevance, anatomy, histology, and the goals of this study. So atherosclerosis is a process of endothelial injury that can cause a plaque to form, thus obstructing the lumen of the artery. So as you can see on the left, a patent lumen of the artery, no obstruction, whereas on this side, we have obstruction of the artery. And as you can imagine, that would lead to a narrowed lumen and reduction of blood flow. So this is renal artery stenosis, and atherosclerosis is one of the causes. Fibromuscular dysplasia is another that I will get into shortly. But if the stenosis or the narrowed lumen is bad enough, we can have end-stage renal disease or renal failure, and the patient would need to be on dialysis or potentially receive a kidney transplant or get on the kidney transplant list. So this does have implications for the patient. And we wanted to look into this study to see if there was an association between this process of renal artery stenosis and age of our donors. Lifestyle like smoking, diabetes, having a high-fat diet, hypertension, those are all things that can cause endothelial injury, which lead to an atherosclerotic plaque being formed. As one clinician put it, the last time we all had clean arteries or clear arteries was when we were a neonate. So we all have some degree of fatty streaks or atherosclerosis in our arteries, but it doesn't get to the point of renal artery stenosis or narrowing of that lumen until the stenosis is quite progressed and severe. This does have implications for patients beyond the dialysis or end-stage renal disease. They can also have heart failure. Atherosclerosis can lead to coronary artery disease, peripheral artery disease, but this study was specifically looking at the renal arteries. This is a nice graphic showing the progression of plaque formation. So when I say fatty streak, this is what I mean, just a little bit of atherosclerosis on the wall formation or fat buildup essentially on your arterial wall. Your lumen is not too narrowed, but as you can see, as it gets further and further progressed, there is severe stenosis, which our pathologist, Dr. Dobson, shared that it's greater than 70% stenosis or narrowing of that arterial lumen, where we really have significant clinical implications. So in this bottom area, we would have critical stenosis for the renal arteries, but if this is in the heart, we could have sudden cardiac death. So as I mentioned, this is a serious condition that needs to be appropriately managed, and having the ability to screen patients before it gets too severe could be helpful for the clinician and the patient. And so that's why we wanted to do this study, was to look into or to use this as evidence for potentially screening certain age populations for renal artery stenosis. So as I mentioned, atherosclerosis is the most common cause. 90% of renal artery stenosis is due to atherosclerotic plaques. However, there is another cause, fibromuscular dysplasia, which is a non-inflammatory process, and it's less common, but we did find that in our donor population, which was an exciting, unexpected find that I will get into later. So this is a helpful diagram of those fatty streaks that I was mentioning. So you can see the yellow here. And the renal artery is coming off the aorta, as most of us know. So that's a really high pressure area, leads to turbulent blood flow, which would lead to plaque formation. As this image shows, you can see the yellow getting bigger and bigger, which is the progression of that atherosclerotic plaque. As we would expect, if the plaque gets bigger, that artery is going to get more narrow and the blood flow is going to be reduced. So all our kidney knows is it's either getting blood or it's not getting blood. And if it has less blood flow, the kidney thinks, oh, our blood pressure must be down. So it turns on that renin, angiotensin, aldosterone syndrome system, kicks up our blood pressure, leads to refractory hypertension, which just means there's hypertension that is not responsive to medications. So if you have a patient that comes into the clinic, they are on high blood pressure medication, but it's not really working, that's because we're not necessarily treating the cause, in this case, renal artery stenosis or atherosclerosis. So we wanted to use this to see if we could screen certain patient populations and make treatment better for the clinician and the patient themselves. Both of these, atherosclerosis and fibromuscular dysplasia, alter the vascular microanatomy, which we will look at and under the microscope. A quick introduction that many of us probably don't need to anatomy. So this picture was taken from one of our donors, and this is the kidney. And then we can see our renal artery extending from the aorta to the hilum. It does branch early, right at this point, right past that arrow. So we had 6 that branched early. So in these individuals, we cut before the branching point, because once the renal artery branches, it does technically have a different name. And so for consistency with our population, we were only studying the renal artery. So we wanted to make sure that we weren't including arteries that technically had different names. So quick anatomy review, moving on to histology. So both of these images are hematoxylin and eosin. And as you can see, it's pretty uniform on the left. So this is an artery, median muscular artery, which is a renal artery. The area in the middle is the lumen, doesn't appear to be occluded. It's uniform. There isn't any bulging of any part of that artery. This is a zoomed in view of the same section. So you can see the squiggly pink line is the internal elastic lamina. This all underneath that is the tunica media. And then the lumen is up here. The tunica intima is typically quite thin, but knowing the distinction between the intima and media was super helpful for us to identify whether it was a atherosclerotic plaque or fibromuscular dysplasia. And that's where this stain, which is Verhoeven-Giessen or an elastin stain, this stain really came in hand because we can see the tunica media, and then the black line is the internal elastic lamina. So the point of this stain was to really highlight that lamina. And as you can see, this internal elastic lamina is the same black line, but then all of this on top is plaque. So knowing if our renal artery change was on top of the internal elastic lamina or between the internal elastic lamina and the external elastic lamina was helpful for us to identify either a plaque or fibromuscular dysplasia. And some components of a plaque would be the central necrotic core. And that is what we can see in the middle of this plaque right here. So as I was mentioning with the Verhoeven-Giessen stain, it really highlights the internal and external elastic lamina. So we have those 2 dark lines, and in between them is the tunica media. This was taken from a sample that did have plaque on it. So all of this is plaque that shouldn't be there in a healthy artery, as we see in this previous slide where there's nothing on top of that internal elastic lamina. We also use this stain, the VVG or elastin stain, to help verify our plaque measurement. So we took both the H&E and the VVG, measured the plaque on both, and then, we compared the measurements to that. So it was helpful to have the internal elastic lamina to know more precisely where we should be measuring from. This is taken from Robbins, and it's a helpful image of what a plaque looks like. This is a Mason trichome stain, which highlights collagen blue. The F is the fibrous cap. The C is a central necrotic core. So again, those are parts that our pathologists use to help identify atherosclerotic plaques. And then you can see the unaffected section of the artery and how narrow that is compared to the other thick, extensive plaque. The middle image is an elastin stain as well, and this is another view of that VVG stain that we also use to highlight our internal elastic lamina. So the goals of our study were to assess prevalence of both atherosclerotic plaque and fibromuscular dysplasia in the renal arteries, and then compare the prevalence of those to age and see if there was an association between certain ages of our donors and prevalence of either fibromuscular dysplasia or atherosclerotic plaques. Moving on to our methods, we used 29 formalin embalmed cadavers from the Kansas City campus. One renal artery was dissected per cadaver, and we measured the renal artery once we dissected at the bifurcation off the aorta and before the renal artery bifurcated at the hilum. And then we measured that, set the caliper to 5 millimeters, and then we cut in 5 millimeter segments. We stained each of those segments with tattoo ink of different colors. So black was proximal, then it went red, green, in that order. That helped us keep track of the artery, whether it was proximal, middle of the artery, or distal. And then we sent this off to the University of Missouri One Health Biorepository Lab, where they stained all of our sections with H&E and VVG. And then once we got those back, we used the Lycro Microsystems Microsoft software to assess whether plaque was present. This is where we found the unexpected finding of fibromuscular dysplasia. And then we also used both stains, our H&E and our VVG, to measure the plaque size. We only used Kansas City donors instead of both Kansas City and Joplin due to cost. The cost of the histology was extensive, so we wanted to keep that in mind, and that's why we just chose to use the Kansas City donors. These are some images of our artery collection. The left image shows what the artery looked like when it came out after dissection. We used a hemostat to clamp the proximal portion to keep track and not get lost on which end was which. And then we measured using a caliper, and then we set that caliper to 5 millimeters, cut the artery into segments, stained them with tattoo ink, packaged, sent them off. And once they returned from the lab, this is how they appeared. So we had both the elastin VVG stain and the H&E stain. For measuring our plaques, we measured at the widest portion of the plaque for consistency. And as you can see in this image, this is an H&E stain. This is the lumen, and then the outside of the artery, or the adventitious, over here. You can also see the tattooing. So that black pigment is actually the tattoo ink. So just looking at this image, I can tell that this is the most proximal section of this artery. So that was a really awesome finding, was how well the tattoo ink showed up. You can see some components of the plaque that we talked about previously, the central necrotic core, as well as this purple or basophilic area, which is the dystrophic calcification. And then we measured from the internal elastic lamina across to the lumen. We measured each plaque on both H&E and VVG. And as you can see, it's easier to be precise with the VVG, knowing that that black line is the internal elastic lamina. So that just helped us be consistent in our measurement. Moving on to our results. So this is a chart indicating the percentages of donors in each age category that had either atherosclerotic plaque or fibromuscular dysplasia. So the purple is plaque, and the orange is dysplasia, and black showed no renal artery changes. So in this youngest age group, starting at age 50, there was a higher prevalence of no renal artery changes, which is not too surprising. And then as we get older, we do see an increased percentage of renal artery changes. Specifically in the 61 to 70 age group, we saw 60% plaque, but 80% total renal artery changes out of the whole population. That's including both fibromuscular dysplasia and atherosclerotic plaques. And 71 to 80 and 81 to 90 had a high percentage of renal artery changes, and even the 81 to 90 had 100% of their donors had some sort of renal artery changes, whether that was fibromuscular dysplasia or plaque. So as you can see, 50% had plaque and 50% had fibromuscular dysplasia. That was a really interesting finding because the data that has been published on fibromuscular dysplasia shows usually you don't see it in individuals older than 50. So that was an interesting finding for us that we did see, that we saw it, period, in our donor population, since the majority of them were over 50, and that we even saw it in individuals older than 80 as well, because we even had 25% that were older than 90 that had fibromuscular dysplasia. We did run a chi-square on this data, and we found no significant difference in the percentages of both atherosclerotic plaque and fibromuscular dysplasia between the age groups. These are some examples of our plaque measurement. So these are all different donors. As you can see, we measured across the widest area of the plaque to be consistent, and each of these has components: the dystrophic calcification, the central fibrotic core, and then the fibrous cap, which you can see is closer to the lumen. And this is the fibrous cap over here. Our average plaque measurement was 1.55 millimeters, and all of these images on this slide and the next slide are shown at 4 times magnification. So these images are the same donors in the same area on the slide, but on the VBG or elastin stain. And there was something I wanted to point out with this image. So you can see how it is fragmented, or there's some breakage. That is one of our limitations, and it's essentially just due to the histologic staining process. So these plaques have calcifications in them, and they have to be decalcified during the histologic process. But these arteries are so delicate, and these slices are just a few microns thick. So it could just be due to the histologic process. But thankfully, that didn't impact us too much, but I did want to include that so that way people were aware of it. So our average size in millimeters by age category, we ran an ANOVA on this data and found no significant difference between the average sizes of the mean difference between age groups. For example, our youngest age group of 50 to 60 and our middle age group of 71 to 80 had a similar size of 1.37. And then we included our standard deviations as well. So our largest average size was in the 61 to 70 age group, but that could potentially be due to having a higher percentage of numbers, essentially. So one of our largest plaque was in this 61 to 70 age group. So that could be why we found that increased number for that age group. But like I mentioned, there was no significant difference. Moving on to fibromuscular dysplasia. So these images are taken from the same donor, one at 4 times magnification, one at 10 times magnification. And if you look closely, you can see that squiggly line right at the lumen. So that is our internal elastic lamina, and fibromuscular dysplasia is most commonly a medial type, meaning it's in the tunica media. So seeing that internal elastic lamina and knowing that our changes to the renal microvasculature are in the tunica media helps us determine that it's fibromuscular dysplasia instead of being a plaque. So this is just a zoomed in version, and you can see those changes right here. Typically, the fibromuscular dysplasia presentation or epidemiology is 9 to 1 female to male. However, our results were that only 2 of our 6 fibromuscular dysplasia individuals were females. So that was an interesting aspect that we didn't necessarily expect to find. However, the data that is out there on fibromuscular dysplasia is a bit older. So this could potentially have implications for expanding sample size and supporting and refreshing essentially the data that's out there on fibromuscular dysplasia. Because like I mentioned, we found an older population with fibromuscular dysplasia and a more predominant male population, whereas the data shows a younger female population. So the implications of these unexpected findings could be pretty exciting. This is fibromuscular dysplasia on the VVG or elastin stain, and just further supporting this internal elastic lamina is not interrupted. It's unaffected as it should be, whereas it could be interrupted or affected in atherosclerosis. But we see the changes in the tunica media in between the internal and external elastic lamina. An unexpected finding, but something that we documented, were accessory arteries that we found while dissecting. So typically during embryology, there are accessory vessels supplying the kidney, but those should regress. In these individuals, they did not regress. In this kidney, we can see the main renal artery right here coming off the aorta, but then we also see connections from the aorta directly to the kidney in this bottom one as well. In this middle image, there are 3 arteries coming off the aorta supplying the kidney. And then in this image on the right, it appears to be a duplicated renal artery where it's coming off directly off the aorta on both sides. If you look closely, you can see it on the other side as well. Similar length, similar diameter. Interestingly, none of these individuals shown in images had plaques in their arteries. So for our conclusions, the histology staining in the donor tissue really was much better than I could have ever expected. I really geek out looking at the histology, and I think it's so exciting to see how well it turned out, even post-mortem when they've been formalin fixed, as well as the tattooing showed up really well. So those are exciting options for individuals who want to do more histology studies in cadaver donor populations. We did have a 71.4% prevalence of arterial changes shown. So 20 out of our 28 donors, we excluded one donor just due to a young age. He was 36, so we didn't include in the 50 to 100 age group. So 20 out of 28 showed renal artery stenosis changes, whether that was atherosclerosis or fibromuscular dysplasia. The age group 81 to 90 years had 100% prevalence, like I mentioned. Half of that was fibromuscular dysplasia and half of that was atherosclerosis. And then the age group 61 to 70 years had the greatest prevalence of atherosclerosis plaque. Future directions, we hope that others can take this and increase the sample size, as that was one of our limitations. And then we hope that this could also serve as supporting evidence for screening at-risk patient populations. For example, you have a 60-year-old individual who smokes and has high blood pressure. They could meet criteria to be screened for renal artery stenosis. And if they do meet that criteria, that would mean they would have some sort of imaging modality, whether that's ultrasound, renal arteriography. And then if they are found to have renal artery stenosis, they can be better managed with medication therapy, with the clinicians now knowing that they have to treat at the kidney. And then they could also, if it's extensive stenosis, they could go through stenting or angioplasty. Further assessments are on the way for this study. So we have a MOVAT pentachrome in the works. It should be coming back here shortly. And this is what is pictured at the bottom. So it kind of looks like a rainbow. I'm super excited to get it back and look at it. But it stains collagen yellow, mucin in blue, elastin and nuclei in black, and muscle in red. So that way it really helps us differentiate what we're looking at. So it's just a further example, or it's better to further assess our fibromuscular dysplasia. And we got that after the fact because I did mention that we weren't expecting to find the fibromuscular dysplasia. And then we also are going to be measuring our tunica media underneath the plaque and seeing if there's any compression of that tunica media. Limitations, we did have a limited sample size. We also had limited medical records on the donors, so we were unable to assess if they either passed away from renal artery stenosis implications like cardiovascular disease, or if they had end-stage renal disease, were on dialysis. We weren't aware of that information due to the limited medical records. And then, like I mentioned, the breakage during the histologic process. I would like to acknowledge the One Health Biorepository at the University of Missouri for staining my incredible research team. I could not have done this without them. I'm really thankful that I picked these individuals to work with. And then, of course, our gift body donors. They donated their body to science for research and for learning. And I'm so thankful that we get the opportunity to conduct research projects in a cadaver population, because not everyone has that opportunity. So couldn't have done it without them. These are my references, and that is what I have. So thank you. Any questions?
Thank you so much, student Dr. Chant. Appreciate your immersion. It's plainly evident that you do enjoy pathology. Thank you again for that. So there are some hands in the chat. Dr. Ollinger, go ahead.
Good job. With each of you, when you say your sample size is a limitation, I don't know that that's always necessarily true. 29 is a good number. Bigger numbers are always better, but you can definitely capture what you're trying to capture, I feel like, with 29. The histology, anyone who's ever sliced tissue knows that you're going to have those breaks. That just is kind of how it happens sometimes. So it's not, as long as you can find a section that was unaltered, or undamaged by the break, you're also good there too. So that was it. Good job.
Thank you.
Kiana, go ahead.
Good job, Ginger. I love the histology. There's those slides, and that stain makes really pretty pictures, I think. But my question is, what you said that you only chose one artery.
Mhm.
Did you like consistently choose left or right?
So that was a consideration we had, but then as the students were going through their dissection, because we did wait until after the students dissected their kidneys, and we removed one kidney, or the students removed one kidney, I let them decide which side their vasculature looked better, essentially. So the students kind of got to be involved in that, but we did have one donor where both kidneys were removed. We did not include that donor because we wanted to be consistent that we were dissecting exactly at the aorta and at the renal bifurcation. So we didn't include that donor because both kidneys were removed by the students, but no, it changed. It was differing right and left, just depending on which kidney vasculature essentially looked better when the students were dissecting.
Yeah. Do you think that like affected your how many like renal artery stenoses you found? Like, because are plaques usually presented bilaterally in renal artery stenosis?
So that's a good question, and it's something I talked to Dr. Seegers about, and we initially had planned to take both, and then since we were looking at the age of the donor, it's, whether we took right or left, that age doesn't change. So that would essentially be like a lot of data that we didn't necessarily need. And then again, cost was also a factor in that. That would have been sending 120 or requesting 120 slides versus 60. So I don't believe it impacted it because if there's going to be atherosclerosis in the arteries, it should be on both sides. So it's a good question.
Wait, I have one more question.
Yeah.
Did you find any donors, or I don't know if it's possible, that had both renal artery stenosis and fibromuscular dysplasia?
Yes, thank you. I meant to mention that. So we did have one. They had a large plaque at the bifurcation, and then they also had fibromuscular dysplasia. So we did have one individual with that.
Interesting. Okay, thank you. Good job.
Yeah, thank you.
Dr. Dobson, go ahead.
Hey, thanks. Kiana, your question also has implications for fibromuscular dysplasia, which seems statistically to be more common on the right. And I didn't think about it till Ginger's presentation today either, in terms of how many of our vessels were harvested right versus left. So this FMD thing is going to kind of morph, I think, into a bigger project now that we've kind of seen some of these results. But that's a great question to think about, bilaterality.
We are getting in on the ground floor, Dr. Chant, and establishing a platform for others to follow, or you to follow in the near future. Now, Dr. Hopper, go ahead.
Yeah, thank you. Student Dr. Chant, you've just done a really nice job with not only the work and the hypothesis-driven investigation, but your presentation today. Great tone, great pace, great presentation. My question is, and I think Dr. Dobson kind of set the stage for this. You shared some surprise findings and some impactful findings. And I'd like to hear you talk just a little bit more now as a future clinician, how that might be translated into clinical diagnosis, clinical practice.
Are you referring just about the fibromuscular dysplasia that we didn't expect, or the arterial changes, or?
Any and all of your work, how will you use that to provide evidence for your practice or your work as a clinician?
Yeah, thank you for that. I think the unexpected findings were exciting and always expands the breadth of our work. And if anything, it just helps us as a reminder to stay open-minded. And when we're talking about patient care, it reminds us to not be so narrow-minded on, well, if we think this is a diagnosis, it has to be this diagnosis, and this is the way we're going to go. I think it's a good reminder, or at least finding these unexpected findings, and even saying, okay, we expect fibromuscular dysplasia to be more common in female donors, and then that not being the case for our findings, then that just makes you take a step back and ask more questions, essentially. And then Dr. Dobson and I were looking at the research, and he was like, well, this research is pretty old, so maybe we could ask more research questions and do more research on it. So I think if anything, it just helped me to keep an open mind about what I was looking at, and also ask more questions. And yeah, and it just makes me really excited about medicine as a whole. And I got into medicine because I love it so much. As you probably could tell, I geek out on stuff like this. And I could make this picture that we're looking at my background because I think it's so neat. So the arterial changes, I remember when we were doing the dissections with Janice and Christoph, we all got so excited when we found the accessory vessels, and we took pictures for research purposes, of course. And so if anything, I think it's just a good reminder for clinical practice to take a step back and say, this is the most likely, but there are other options as well. And kind of like I mentioned with refractory hypertension, if the medication isn't working, then what else is going on? And it just it allows us to take a step back and say, what else could we look at, or what else could be going on here? Just because this person isn't a young female doesn't mean that they don't have fibromuscular dysplasia, for example. So yeah, thank you for your question.
I had a quick question. Do you think those with accessory renal arteries that you discovered, the fact that they don't have any stenosis, is that correlated or causative? And if it's causative, in other words, do they have some kind of advantage of those over those of us who may not have accessory arteries in some way, shape, or form?
That's a great question. And Dr. Dobson actually shared with me this morning that 88% of individuals have duplicated, so have two renal arteries. I don't know if there would be an advantage. When I saw that none of those individuals who had accessory vessels had plaques, my thought was, well, maybe the pressure was spread out a bit over those arteries instead of going the pressure from the high pressure aorta into the renal artery. Maybe that is dispersed a bit, so then we have less opportunity for turbulent blood flow and plaque formation. But yeah, that's a great question.
I was thinking the kidney would be perfused better and might be a little better at getting rid of stuff. I don't know.
If I could interject, generally those extra branches they're not really extra branches. They're just, the renal artery is going to branch into 5 branches, go to the 5 different vascular parts of the kidney. And usually when you have one of those extra ones, it's just a branch that would have normally happened later. So I don't feel like the kidney is more perfused. I think it's just a branch that normally would be there, but normally stem from the main renal artery.
I see. And did you say that 80% of folks have this kind of a structure? Is that right? Yeah.
So in this image, the duplication on the right image, Dr. Dobson shared that 88% of people have that, which was really interesting. So I would have to do more. We were just talking about that this morning, but so I would have to do more research on that.
Kind of autopsy series, but maybe the anatomy faculty that have seen a lot more of this on a routine basis have a different experience. I'd be curious as to what Dr. Olinger, Dr. Dennis, and some others, Dr. Zolniers, have seen in terms of these accessory renal vessels, you know, just as a malformative or abnormal process.
I agree. I think it would be interesting to see if what I just said was actually accurate, that they're just, because I mean, you're going to have those 5 branches that come from the renal and go to the 5 specific vascular parts of the kidney, and that's kind of how the kidney is broken up. It'd be interesting to trace that and see if it is actually just one of those branches, or if it is a completely and entirely different branch. And I will let the embryology folks discuss the branches that are there initially and then are supposed to go away.
Yeah, I mean, I would say just accessory renal vessels in general, whether veins or arteries, are both totally plausible in the population. But most renal arteries that are accessory are end arteries. So I don't know that it necessarily impacts initial blood flow into the tissue, but it definitely impacts if you inadvertently ligate one of those, because then it's not arterial supply that's shared by other territories, like a watershed.
It'd be fun to inject those vessels with colored latex to see what the blood supply to different parts of the kidney actually is from those accessory vessels.
This is what I wanted to add. Here on the picture, I don't see the branches going to the adrenal gland. Did you have them and you removed them, or?
That was, so those vessels are so tiny and delicate. We only focused on the renal artery, and whether, at least in the KC lab, not all of the students were able to find those and dissect them out completely. So we didn't include those in any of our pictures or anything like that.
But practically they were there.
In theory, yeah, we would hope
Okay.
that they would be, yeah.
Thank you.
There's a question in the chat from Dr. Hopper. As this is end of dissection opportunity, has there been any conversation about reaching out to UMKC or KU to expand this study?
Thank you for that. There has not. The thought, since both of my research assistants, so to speak, or research team, Christoph and Janice, are first years, the hope would be that they could expand this, since they have so much experience with it already. And then there has been talk about including another fellow next year, since they will have access to the upcoming donor population. But as of yet, there hasn't been any conversation with KU or UMKC.
Well, just so you know, the best research raises more questions. So you should feel good about that. Dr. Ollinger, go ahead.
We in the past have tried to reach out to KU, and even though we have people there now, we've got Barth there and Sarah Keim there, it rarely pans out for whatever reason. UNMC does, did I say that right? No, UMKC does, I think pro section, last time I checked. And so they are still, they just have like a handful and they keep them pretty pristine. So we're not really allowed to do much there. I don't have any connection there either, but University of Nebraska Medical Center, we still go there once a year and try and collect data from their cadavers. But with a project like this, it's tough because you're going to be cutting stuff off and taking it with you. Not everyone always is super excited about that prospect.
Well, and that's precisely why because I was planning on going to Nebraska, and then the more I thought about it, I was thinking, well, I'm taking their arteries, and I didn't know, I felt like logistically that was a big hoopla that I didn't really want to go into, so we just stuck with Casey.
Speaking as a former Nebrasky, a guy who grew up in Nebraska, you want to avoid it at all costs. You know, their state slogan is Nebraska. It's not for everybody. Seriously, they
That's
actually
good.
changed it to them. All right, Dr. Dennis, go ahead.
I was just going to add the other issue, and Ginger mentioned this in her presentation, is this particular set of staining. I think honestly, all the KC fellows at some point in time decided to use the MU biorepository for staining. It's been really great, but this particular set of samples was astronomically more expensive by comparison. So any sample size that we are adding would have to be really heavily considered so that we can be as thrifty as possible, simply because it is much, much more expensive by comparison to the other staining that we've done for other projects.
That's, cost is always a consideration for driving every project. So I appreciate that, Dr. Dennis. I'm going to say this and I'm going to be quiet. Student Dr. Chant, if you make that vision of that histology slide right there, put some KCU branding on it, I will make that my backdrop. I think it's both artful and on point and definitely carries the KCU colors. So encourage some artistic expression as well. And if you're up for it, I will be an early adopter.
Oh, absolutely. As I was doing some final tweaks, changing arrow colors and things like that, I noticed that because I was sticking with the purple and orange of the KCU slides, and I was like, oh, most of my images are either pink, purple, and have some orange in there, and so it worked out well. But I think this is such a neat image, so I would be happy to. And I just want to thank everyone for their questions and discussion. I really appreciate everyone listening.
It was great.
Thank you.